sir, coming.
On kar dena, please.
You finish your pump failure? Or still remaining?
Done all your assessment and other things.
No, sir.
Practical assessment, pump failure?
No.
No, not power failure not done yet.
Pump failure.
You finished?
No, assessment is remaining.
No,
sir.
no.
Assessment one.
It's remaining.
And still
Not
remaining.
yet.
Not done.
Okay, fine.
Start
Where is it?
Everyone is in now?
Yes, like yeah.
Okay. So the same child, 10 years, a known case of multiple sclerosis on immunocompromised and developed pneumonia, ARDS, ventilator, then went to ECMO. On ECMO, remained stable for 4 days, and problem started after 5 days. Initially, line kink, venous line kink, then sweep gas failure. Then he developed GI bleed and bleed from all everywhere. So it was an early sepsis with DIC, which was managed well. And then his patient is going to fluid overload and AKI, so need to start at CRRT. 3 days back, CRRT was started. Now things were stabilized. He started passing good urine, so we have stopped CRRT. Okay. These are the parameters what you can see now. Lung is still not improving, so the primary physician says that why don't we prone the child and see if things improves after doing a proning. So it's over to you now. The primary person wants you to prone this patient.
SPO to 94 ఉంది కదా. SPO to 94.
The swipe gas,
Saturation is.
sweep gas.
Suggestion 94.
Latest ABG.
ABG value.
Latest ABG.
Latest ABG is pH is around 7.38, PO2 is around 56, PCO2 is around 34, and bicarb is around 24.
Sweep gas, sir. Sweep gas.
Sweep gas is 2 liters.
2 liters. So I think we can prone and see and try to ventilate the dorsal regions. Maybe that will improve and it may help us with weaning as well.
How's the X-ray, sir? Chest X-ray.
Chest X-ray.
I'll show you the X-ray.
X-ray.
X-ray is not completely. The first day X-ray.
It is almost similar.
Same.
We can say we can increase the OPCO2. We can.
Peak pressure is 24. Peak pressure is 24. Plateau is 10. So it is within normal limit, I think.
Last one.
FiO2 is 30%.
Last one.
It's 86. 86.
So
So the child is 20 kilo.
Child, that's fine, right?
Madam,
4 ml.
Vitally, hemodynamically stable, sir, without vasopressors. Without vasopressors.
Stable. And P plaque is
prone
also
too
less
early.
than
How many days on ECMO?
Today's date 13 on ECMO.
13.
13.
It will.
Whether we'll have a discussion whether we need to actually go for a proning or not. So
Yeah.
if the parameters
X-ray
are
we saw.
acceptable and in good,
X-ray is still not improved.
See, if there
Hemodynamically
is a
stable.
weaning issue, we can try proning and
Yeah.
see if we can ventilate the dorsal segment. At the same time, ECMO is there, and then it might help us with the weaning. That's what, because already 10
days of
more than
ECMO.
10 days are over, so we can give it a try.
No, not on
No,
inotrope.
No, patient is stable right now. Vitals are okay. I mean, there's no contraindication for proning as well.
Yes.
So we should.
Have we given, sir, a winning trial? So
Only left side one lobular consolidation is there, so can bronchoscopy or anything can be done and see whether any mucus plugs are removed.
On ECMO procedures we would preferably avoid because bronchoscopy apparent and all things indicate high.
No, only one area is involved, so why we have, whether proning will help.
You can do bronchos.
No, the
It's been
X-ray has
lying
not
down
improved
for
from the
13
day one.
days.
So
Already 13 days on ECMO.
Yeah.
We can
The-
go ahead with proning.
And there's still hypoxemia.
yeah, we can
50.
try that one session of proning because it has not, lungs haven't improved. Even the saturations are okay, but the lungs haven't improved. We can't go continuously with on ECMO for long. So if proning will help, it would be better for weaning purposes as well. One session now the patient condition and vitals are stable enough, right? So proning might help if the dorsal segments are recruited and if the lung changes, I mean the X-ray findings are, once the proning is done and deprone and the X-ray improves, that it's better to easily.
So if everyone agrees, then we can divide into the teams and one person can look after the.
I'll keep an eye
So
on
there will be,
the
we'll
ventilators
do
and
First
vitals.
we'll
One
check
first
the
check the
connection.
lines.
We'll
Examine the patient.
patient first.
Yeah.
regarding the cannulas, we'll do one thing, we'll as per we had, we'll divide ourselves into teams.
Yeah,
So
Two
one,
of
two of,
saturation is 94. Can we wait on proning?
It's on you. The primary physician said that you go ahead with the prone. So that is what the
we
we
want
want primary
it-
team's
Can we,
decision
can
is.
we reduce
Can
the
we
swipe
do
gas?
Acceptable,
Can we reduce
acceptable
this is-
saturation in
This is
the
on
saturation.
94 on
in
100%
ECMO is
FI tone rate.
88%. In acceptable saturation in ECMO is 88 to 90.
so we
Yeah,
will try.
but this is 94 on
100%.
100% FI tone
So-
ECMO.
If
The
we
primary
try,
person feels that if we prone, the lungs will show some recovery and we will able to wean off from the ECMO. That is what the primary physician.
We can try reducing
if
FiO2
I vote on the sweep gas and see if the same saturations are being maintained.
Causes
If
of
it is
other
not
causes of
maintaining, then
hypoxia other than ARDS has to be ruled out, like pulmonary edema, pleural effusions, any contusions of the lung,
Mucus plug.
mucus plugs,
Mucus plugging.
or
So we've done CRRT and come off CRRT. Are we on negative fluid balance?
Yeah.
Yeah. So
So now I think.
I think on 100% FiO2 on ECMO with full
So
flows, we are
I
on
ag-
2 liters flow. We are on sweep also at
one.
2. Yeah, 1:1.
The
we are
20
on
kg child, so it's almost 100 ml
100 ml per kilo.
per kg. So it's a high flow for
High
the child.
High flow. And the PaO2 is still less than 60.
lung ultrasound and echo to be done to rule out any other causes of hypoxia, means other than ARDS alone, any other cause of hypoxia first to be ruled out. Gas failure.
The only
Sweep
other
test.
thing is it's cumbersome and maybe not feasible is CT to look for basal atelectasis. But instead of that, we can plan together for proning and seeing
So I
if there's
agree with you
improvement.
only on one point. Bronchoscopy can still be tried before proning. That also can be done. Do the toileting and remove the mucus plugs, followed by the proning. That
Yeah,
will
we
be
patient-
our
must
plan.
do
the patient-
The
bronchoscopy.
flows also, na, we can
And
reduce
flows,
the flows and we can see whether
oxygenator.
he desaturates or not. If he is desaturating, then we can again increase the flow and then we can go for proning.
So why don't we do proning and then do that? That will be safer.
And he wants to prevent the proning, whether we can
Yeah.
prevent the proning. And but I think with our 100% of FiO2 is
FiO2
94,
we
so
should
there is
go.
no meaning to reduce the
think
flow.
we'll go
He will
ahead
desaturate
and-
again.
So
Yeah.
the discussion is between like we want to prone or we don't want to prone.
No, we'll-
if we are
Yeah.
going for with
There is no
The debate will go on endlessly.
I'm sure it will be 10 o'clock in, then you will not have any consensus.
I think we'll
So-
go ahead.
So
There is no contraindication, then let us prone the
let's
patient.
go ahead and
go
then
ahead.
see how
Yeah.
it
We'll take the consent.
Concern
and,
from that end.
We'll
explain
explain
the
the
relatives explain
that
that
we are
and
going to
clearly
prone.
that we are going for the
explain the
procedure.
complications and pros and cons of the proning. And then we'll make the team, divide the team. One team will look after the ECMO, one team will look after the proning. Right?
And one
So-
should
We'll
manage
look
the
at
airway
the
as well.
circuit and the
Yeah, so we'll just
We'll check the cannula
Cannula
positions.
positions as well, if it is well placed and well.
okay, we'll
So cannula position is okay. There
Just,
is no bend. The
lose
upper
any
cannula
tight
is
connection.
completely.
Yeah, make sure the
this
length
drain.
is enough.
Yeah,
Check
this
the
is
lengths
okay.
actually whether it's adequate for
it should
proning.
be properly tied. Sir,
Cover the
cover
eyes.
to cover
Do we
Cover
have-
what?
bandage to cover the eyes.
That
Cover
should be
the-
okay.
Yes, okay.
Whatever
Yeah,
is there
yes.
should be okay, yeah. You have
Yeah.
time.
Pressure point should be covered.
It's only
So if we are
Can
planning for
cover.
proning, I think we will do the preparations first, covering the
Eyes.
eyes and everything, so to pressure and the pressure points as well, and along with the cannulas.
First the eye and then we
నార్మల్ గానే ఉంది కదా అంత
will secure the cannula also.
Prone to this side. Prone to this side.
And yeah,
That side.
we'll secure with
We'll
the
prone to
cannula
side or
The
this side?
person on the
This side. This side.
Right
person on
side.
the head end can hold the
Yeah,
cannula
I will hold
and the
the
ET
tube
tube.
and
We
cannula
need
both.
the pillows here.
We need
One on the shoulder, one on the
3
pelvis, and one on the
pillows.
knee. Yeah, three
Three
pillows.
pillows
3
are required.
pillows. But this is a child, 2 might be enough.
So one here and one
One
here.
here.
One over the
Because
chest,
abdomen
one over
has
the
to
pelvic
be
region.
free. Over the
One over the
pelvic
chest
region.
and one
We'll
over
shift the
this.
patient towards the cannula side.
So
No,
should
we'll get the pillows and then we'll cover with this.
we get
Yeah.
pillows will get or they're coming? Okay.
Okay. So then
But
we'll
how
check the length of the circuit. Central, thank you. Central lines we should ensure they are not.
2 are fine.
Kinking,
Is it
no
kinky?
kinking.
2 are
Okay.
fine.
This
Yes,
one
2
shouldn't
pillows are
be,
fine.
okay.
But abdomen has a.
Oh,
think
yeah.
It's
two
a
are-
child,
One is
no?
the
2
child,
is
one
Two is
enough,
enough,
yeah.
Keep the abdomen
Make
free.
sure the cannula is,
Then cover it.
okay.
But
Yeah.
then. Yeah, correct.
Yeah.
What do we do?
Okay, when the railing is being removed, make sure
See,
cannula is.
output
how will we-
Sir told
it will go
output has
down?
already started after CRRT.
Pulmonary
So if there is
hemorrhage.
if there is a pulmonary hemorrhage, then
For the past few days, the output is fine.
and we have done the CS.
Okay.
Now we need one more sheet down. Wait. Oh,
No. So,
Three of us on this side, three of us on this
Yeah,
side.
one look after the ventilator.
can we have a plan on the proning? First, we'll bring the patient
Towards the cannula
towards
side,
the
yeah.
cannula side. Then we
30
will
degrees to
turn
90
30
degree and then
degrees.
prone,
We'll look
yeah.
at the flows, sats,
90 degrees.
vitals, then 90. Then
And
we
then
will
So
go
only
ahead.
thing is
One
no-
One of the
person
person
lower
will be
sheet.
looking on the
Central line
monitors
and
and
the,
everything.
We'll take the whole this sheet.
This bed sheet it should be there. This
Can
Bed
we,
sheet is not there, no?
I can, no, from the patient here.
Can
Okay,
we
the
hold the
patient,
bed
okay,
down so
yeah.
I can go to the
Sheet
head
nahi hai
end?
na, we need the sheet.
Can we, sir, hold the bed down so I can
Okay, we have to take this
Okay,
sheet.
you guys are doing, I'll keep an eye on the thing.
So,
minute,
yeah,
I will just,
this sheet, there's
bed
only
sheet
this
is
sheet
there.
down. So
Bedlock,
we have to sandwich with this.
bedlock.
The railing is
Then
down
the
and
whole
keep on watch on the tubes.
You understand?
I'll do that.
Yeah. Lines are okay. Length we have
Okay,
to check.
look at the cannula, sir.
Yeah, that's what I'm telling.
Yeah.
Okay.
Unlock the
Be
bed and
careful
just keep
about
the bed
which
down.
That's what
cannulas.
I did. Oh, okay.
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 is 30, peak pressure only 24.
The lines
Drone
are
ఎట్లా
okay.
ఉపయోగపడుతుంది
If there is no
All the lines
vasopressor
are
supports, I
loose.
think we can
Vasopressor is
disconnect
there.
the
We
numbers
should,
as well.
there are
If there
pillows
is no
underneath
vasopressor
also.
supports. There is no vasopressor supports, right? So we can disconnect the lines as well.
Remove, na, the underneath.
On the lines, what we are not using any infusions, there are no hydrotropes,
Yeah,
so we can
so-
disconnect the lines as well.
Ten.
Yeah, we'll disconnect the. Yeah.
No,
We'll
it's
disconnect
okay.
it, so it will
It's not
not.
required to
No,
disconnect.
but we'll need to take the sheet free. Sheet is stuck.
That's there.
You free that sheet from there.
Okay, all are ready.
Take
So
care of that.
This one, this
on
one.
the count of 3, we'll shift the patient to the right end.
Hold
That's
this
fine.
sheet.
This
One
side
we
to
hot sheet.
30
3,
degrees.
shift.
Wait.
Just,
The ventilator, one person looking after ventilator, please.
Yeah. Ventilator sets are okay.
ECMO machine.
Now you want to tilt it to
Okay.
30
Yeah, we'll
degrees.
tilt
30
30 degree.
Towards
check the
towards
flow.
cannula.
Yeah.
1, 2,
This side.
3.
You
Tilt
want
the
to prone type.
Oh,
Onto the edge. Check.
okay.
Check the flow.
Correct, correct.
30 degrees.
Check the flows.
Check the flows.
Next 90
Vitals
degrees.
are fine.
90 degrees.
Okay, now
Flows
90
are
degrees.
coming down.
Flows are coming down. So
Okay,
the
go
flows
ahead.
are coming down. Just check the cannulas and
Yeah, cannulas.
tubings as well. Once again, put down. Don't try to prone. Just put it down.
Check the
Check again the flows. Check in the flows.
Cannula is okay. Cannula is okay.
Return
There's
cannula
no
is
kink
fine.
anywhere.
Check the color.
check the color. Both are same color.
Also, there's
Both are in the same
Yeah,
color.
Both the color are
same
same.
color.
Both
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 colors
are
are
the
same.
bright red.
Yeah.
So most we are
recirculation.
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 So
The recirculation is happening right now.
Yeah.
So shall we
X-ray.
reduce the flow?
X-ray
Flow is already.
So we'll try to
So
reduce the
reduce
Then our
flow and
saturation is
reduce
coming
the
down.
flow. It's
Increase,
Saturations are coming down.
increase the FiO2 in the ventilator.
Increase the ventilator.
1 liter.
Make it 100%.
okay. Okay. We want to see the cannula position on X-ray.
Yeah, we need to see the
Cannula position. We need an urgent X-ray.
Yeah, X-ray will
Get
take
the
some time to
X-ray?
come.
So return cannula is on place. Drainage cannula
Okay,
is
but
on
drainage
whether the
cannula.
position has changed.
Once check the drainage cannula.
The drainage cannula is a bit.
Position of the cannula.
No, no, it's like that.
Can we
only.
see a previous X-ray?
We'll see the cannula position.
with delta pressure is fine.
The delta pressure is maintaining there.
All the pressures are fine.
Only the P1 is.
So
There is the dark.
This is the last X-ray.
is there any issue with the pump? Can we check the pump? So all the pressures are normal. The flow is normal.
That
Flow is
return cannula
improved.
is
Now
kinking.
flow is better.
So distance between
But
the
the saturation
two
are
cannulas
That
is
return
shorter.
cannula is get kinking now.
Yeah, so
Did
we
kinking
have
or
to
the
look for
return cannula.
catheter
No, we'll
malposition.
do a chest X-ray now so
Whether
that
it's-
we can see if they're both. There is a
Recirculation.
Getting kinked here.
Yes, sir.
How
It's here.
No, this is not some.
it is kinked there?
No, no, it's here, no?
No, no,
Yeah, 2.4.
No, no, it's here.
So it's
Now it's
flow
How
is
much is the
We'll
flow?
go for
Yeah,
a chest
yeah.
X-ray once.
Flow
we'll
has
see the
improved.
Flow is improved,
Flow has improved.
but
the
SPOT
Now
is
we
still
have to
low.
look at the color of the tubing again. It's still,
still the
the
same.
same.
Both are bright
Still
red.
there
So there is a
recirculation.
recirculation is going on.
We'll do a
It's
chest
just
X-ray.
bright red on both
We
sides.
can do the sono also.
You can
sono
also
or
shoot
chest
the
X-ray,
sonosite.
it would be
X-ray,
better
X-ray.
actually.
X-ray will check the cannula position.
It will take some time for X-ray to come.
So any
Okay.
sonology we can see. On the ABG as well.
We'll do the pre-membrane
Ultrasound is
ABG,
busy in
please.
adult ICU.
It is in
Pre-membrane ABG, how much is the oxygen?
Yeah, pre-membrane ABG. Okay, pre-membrane ABG is showing pHs of 7.38. PO2 is around 98 and PSO2 is around 30.
Yeah, so
Bicarb is 24.
yeah,
the PO
PO2 is 98, so it confirms that there's a recirculation.
So we have to reposition the cannula.
Reposition
We'll
the
We have to
need an
change the cannula position.
chest X-ray and echo.
So first
No,
we'll
they are
confirm the
not
position of
available,
the.
not
We'll
available.
confirm the position of the cannulas by doing an X-ray.
Why visual exam?
Actually, sonography. We'll check this with
Ultrasound.
sonography. We'll,
Can be.
yeah, we'll check the position with the
Withdraw
sonography.
withdraw the return cannula slightly.
Now, if the cannulas are closed, we have to manipulate the this cannula, the IG cannula.
Drainage cannula. We have to manipulate the drainage cannula.
See, there is a problem. Maybe see, visually examine if the cannula positions are changed
Yeah,
or
we
not.
can
there
do
is
that. It looks okay.
So we'll keep the distance at least 8 centimeter
At
between
least
two the
8 to 10
cannula. 8 to 10
centimeters.
centimeter.
Only this one.
So don't put that return
We'll pull this out.
Femoral cannula has
Drainage
to be pulled
cannula
out.
has to be pulled out.
drainage cannula will.
Femoral drainage cannula has to be come out.
Yeah, ma'am.
Yeah.
But so pull the cannula till the hepatic vein of the IVC under ultrasound.
Okay.
Mm.
No.
No. So,
That's why
yeah,
I'm
so we will pull the cannula.
Till the hepatic vein,
IVC.
hepatic vein entry of.
Wait, no problem.
Yeah, but is there a change in the color?
We
Pull
have
out the
pulled
drainage
the
cannula.
drainage cannula till hepatic vein. So we'll keep the distance between two the cannula at least 10 centimeter.
Then will
No, but we will pull the.
We
will,
can extend the neck.
This is the X-ray.
Sir, we
We
will
can
make that
extend-
flow towards the tricuspid valve.
So it is
We can rotate the return cannula towards the direction towards the tricuspid valve.
no,
That is okay. That is
there are
not an
two
issue.
cannula. No?
Return cannula we cannot do. Drainage cannula we have.
You can
You can do
adjust
towards the tricuspid valve.
So
that
return
recus
cannula we can
circulation
pull.
can
I
be
don't
stopped.
think there's any harm.
Yeah, we can.
Return
Either of that.
We
either
can
of
pull
them.
after looking at the X-ray. We can pull
It's
it.
not an arterial line, right?
Yeah.
So that will be of enough length only, I guess.
The drainage cannula. and the X-ray.
We can put
Sir,
slightly.
can you show the X-ray, please?
What is your decision?
Sir,
Two cannulas there.
sir, can you please show the X-ray again?
Show the X-ray.
There are two
We'll look at the
This
X-ray.
is the drainage cannula in that.
అది ఒక చెప్పారు కదా.
Actually,
One,
the
one
distance
is this,
looks,
one is this.
So drainage is
No,
okay.
this is
Return
the-
is the
this
problem.
the
Return
cannula,
is so-
this is
So we'll pull the
drainage.
return cannula.
And you have to manipulate that.
We can pull the drainage cannula a little bit out.
అరే నాయన.
No, no, child.
Wait. We'll discuss among ourselves. Drainage cannula is in place. We'll pull out the return cannula. It's quite in. We have seen in the X-ray it will not come out. So that decision we'll take. We'll take the drainage cannula out.
Okay. But distance, we have to keep the distance 10 centimeter between two cannulas. So
10 to
we'll
15.
just under USG guidance, and we have the X-ray also here.
Okay.
So
Just mind,
Get a
Gloves
get a
and
glove.
okay. While he's doing that, it's better to
Yeah,
monitor the
we'll
flows
keep
and
an eye
everything.
on this.
So,
When
Okay.
you're doing it,
the current
maybe
flow is
Saturation
fine.
is 56.
Blood pressure is fine.
Yeah.
but
Yeah.
the BP has
Sir,
So you are going to
Saturation
rotate
is-
or pull?
rotate
Rotate first.
First you rotate.
Rotate.
When
Saturation
pressure
is
is
going
got
down.
down, then we will.
Yes, sir.
Yeah. Like,
So
can
USG
one of
machine
you
is
keep
there.
doing
We have the USG machine. So with that echo,
You
we
can-
can. Yeah, we'll check with that. If that is effective, then it is fine. Then otherwise, we'll pull it out little bit.
How much will pull it?
So at least keep the distance 8 to 10 centimeter between two ends.
So how much you are going to pull it?
We can't
Previous
let it come
distance was
beyond
2
the
centimeter.
RASV junction. So till that
So
we can measure and
or sonography
So we have-
we can- before
before.
Before we pull it.
So how to the X-ray. I don't know.
So
सूरज उसको फुल कर दे, फुल स्क्रीन कर दे एक्सरे को.
Saturation is going down.
At least 4 centimeters.
4 centimeter. Pediatric child.
it's hard.
We'll do whatever you
Previously
say.
the length.
Because at least 8 we need, and if it is a big child, 10 centimeters, 8 to
10 is inside.
So we'll pull out first
pull
2
out the
centimeter.
current, one-
2 cent. First we'll rotate. The gloves. I assume
Gloves,
we have
glove.
given the gloves.
We'll pull out by 2 centimeters.
Each time.
Is it okay if we put the cannula at the this anatomical marking of sternal angle?
It is
This is sternal.
And how
Sternal
many times
angle.
I'll show you previous
Sternal
X-ray.
angle.
We'll pull out by 2 centimeter. 2 centimeter.
Yeah. It's a revenge. It's already 6:45, so they want that. Yes.
So I will rotate first towards the tricuspid wall. See if there is any change.
We can
Then pull
see
out
the
by
change
4
in the color.
centimeters.
Observe the change in the color.
Color is the
Observe
same.
That
the
is also same. So I will
Okay.
pull it out for 2 centimeter.
Yeah.
Pull by 2.
Pull out.
So yeah. So I have pulled it for 2 centimeter. Is there any?
Did you pull it?
Sir, I have pulled, sir.
You
Just
pulled?
little bit, yes, sir.
Yeah, now the color is
It's a
changing.
small child, na, so
Okay,
Color
color
is
is changing, yes.
You can fix it over there, I think.
Then we'll take a X-ray, we'll do an echo
Yeah, we'll-
and then decide whether we are in correct
we'll check
place
with
or
the
not.
X-ray. Sir, do we have the post-pulling X-ray?
Can-
Only up.
So we'll fix the cannula and we'll.
Okay, map is maintained.
BVC is occasionally coming up.
Some,
Sats are coming up.
So
Fixed nicely.
mm.
We will abandon our proning. Since we had all these event now, we'll abandon the plan of proning now.
Yeah. He was not agreeing.
Very much.
We will just put this.
ఫస్ట్లో కూడా ఒప్పుకోలేదు అప్పుడు సాచురేషన్స్ బాగానే ఉంది మనం మొబిలైజ్
but we have secured the cannula before proning. Still it went inside.
No, it's okay. I think 90 is fine. X-ray and echo will do.
X-ray again. Yeah, echo we checked. Yeah. One if we ask for.
Recirculation
ABG, yes.
ratio,
Repeat ABG.
Pre-pump ABG.
Pre-membrane and
Pump
post-membrane.
post-membrane ABGs.
Pre-pump ABG na will require pre-pump ABG.
can
This is the X-ray.
Okay. So looks okay now.
Come out
Where
a
is
bit. Yeah.
We'll understand.
And it's saturating, so.
Should be okay.
Mission accomplished.
Yes.
Happy?
Created a problem and sorted
Still,
it. And sorted it.
still we can prone after stabilization.
why to take the risk?
We are
Not today.
proning
We'll
now.
see after 24 hours.
stabilization, after stabilization, if there is no
Yeah.
complication further.
Right.
Yes.
Okay.
Right. Okay, we'll stop here. Okay. The scenario was about two things. One, prone positioning on ECMO, and two, recirculation. Right. The prone positioning on ECMO was a controversial decision. I could clearly see that you were exactly divided in your opinion.
Yeah.
I probably would have had a similar kind of conversation as well. Why should you prone when your SATs are 94? What was the rationale for those who supported proning on day 13 with a SATs of 94?
But I think
X-ray is
when it
still,
is a prolonged time, like almost 10, 11 days,
Does
we
it
are
work?
not it works.
On day 13?
And X-ray is
Sometimes,
same,
I
sir.
mean, if
There
we
is
are
no
stuck,
improvement
that
in
is the
like
only
4 weeks.
option we have.
What
to
makes you think you're stuck on a day 13 on VV ECMO? It's a normal run.
There is no
We
improvement
can
in the
wait
X-ray.
up to 4 weeks also, sir, before proning.
Sorry?
The peak
Before
pressures
proning,
and plateau
we can wait
pressures
up
were
to 3 to 4
normal.
weeks also on ECMO.
Okay.
But there is no improvement in the chest X-ray. It's
My
still-
question is proning effective on ECMO?
Sometimes it
No
works.
mortality benefit.
The only reason why you went on ECMO was failure of proning. And on proning, you're hypoventilating. Sorry, on ECMO, you're hypoventilating. And now you're going to recruit lungs with that hypoventilation settings. How does proning work?
But we have to come off ECMO also, right? If we don't treat the main problem, the lungs. So that's why the bronchoscopy and proning comes. The longer we're on ECMO, we have to deal with more complications. So I think we have to go towards weaning at some point.
What's the evidence for proning on ECMO?
There's no mortality benefit, definitely, but there are trials
No, here
going
there
on.
is no
So the
indication.
trials were negative,
There is no
except for an
indication of
improvement in
proning here.
oxygenation, nothing much
Yes.
they could achieve.
Yeah.
So routine prone positioning may not be a common thing. So I like the way you argued it out. So one group saying, yes, I would try, it's going to be something new, I just want to see whether it works. Yeah, for somebody in Paris it didn't
Group
work.
F, please go upstairs, third floor.
For somebody in Paris it didn't work out, but for me in Mumbai it might work, so I will want to try. Which I thought was okay, but then the counter was, why do you want to do it when the SATs are 94?
Yeah.
What makes you think this will work? So that argument was perfect. Like that kind of debate between the two groups amongst you, and it's worth having such discussions. Overall, you know, prone positioning ECMO, you're on shaky grounds. So either ways, I liked it mainly because unless and until you went for proning, the recirculation would not have happened.
Yeah.
So for me, it was a win. The moment you agreed to prone position, I was actually celebrating because I know what is going to happen next. It's just that, given that you are prone positioning, I thought your preparedness was suboptimal. You didn't anticipate the complications of prone positioning. It was taken very lightly, like how you prone position any patient in ICU. Even then you take precautions. I know you took some precautions, but you clearly forgot some of the important aspects that can happen after prone positioning in an ECMO patient. You wanted to make sure that the cannulas don't move, they don't come out, and this is exactly what literature highlights. You've been given a lot of anecdotal reports about cannulas and other things, but essentially with prone positioning, you need to be prepared for the worst. Before you start prone positioning, you need to spell out what you're going to do at each juncture. This patient is on VV ECMO. You prone position this patient and he has a cardiac arrest. What are you going to do? How? CPR, how? Compress his spine?
And we have to
Make
him supine. Make him supine, then
these things will need to be discussed.
Yeah. Keep the crash
Otherwise, the
cart
team
ready
will be
and all
clueless when it happens. You know these things can happen. So the decision to prone positioning, even though controversial, you went ahead with it. You should back it up with enough enlightenment of how you deal with the various complications. The second thing that will happen is change of position of cannulas. What if there is an accidental decannulation? What are you going to do? See, absolute silence. I can drop a pin. I'm not trying to be critical, but I'm trying to think. I'm just asking you to think through this. What will you do if the cannula comes out?
I'm going to first.
How? You know what will happen? If it's a drainage cannula, if it's a return cannula that comes out, the ECMO machine will take blood out of the body and the return cannula will flush it to the rooftop, right? Within 2 minutes, the whole patient will be exsanguinated. If it's a drainage cannula that's coming out, it will be full of air and the whole pump will stop. It will be a combination of air embolism plus pump failure, double jeopardy. I never heard you talk about that. I'm not scaring you from doing prone positioning on ECMO. Please do it, but you should know how to handle this. The worst could be cardiac arrest. If you prone position and this patient goes into cardiac arrest for some cause, how are you going to do it? It's on VV ECMO. Right? So, big decisions such as stopping anticoagulation, prone positioning on ECMO, doing an intervention comes with a package of challenges which has to be addressed before the procedure, not during or after the procedure. So that's something you have to take back home today. This need not be limited to prone positioning. It can even be a transport to the CT scanner. Anything that you do, think about what are the possible challenges you will have around en route or during the procedure. Talk through it. At least you will be mentally prepared and everybody will be on the same page as you. Right? So that's one aspect about prone positioning I never heard from you. The second thing was, as and when you turn the patient 90 degrees, the cannula positions definitely changed. In your case, the return cannula went deeper into the right atrium. Right? Now, and clearly, You got safety things first, you made the patient supine, which was good. And I like the way you came to the diagnosis of recirculation. You were definitely not given the X-ray immediately, so there were other ways of establishing it. You asked for an echo, you asked for a ABG, all of which established recirculation quite effectively. Am I right? You did cut down the flows, and that brought the saturations up transiently, which again showed that this was all recirculation. So the diagnosis part was okay. And then you got stuck at
To pull out.
how to deal with it. 10 times you look at the X-ray, the cannula will not come out, right? Well, I don't want to make this look silly, but then I think you eventually got to the point after say 10 or 10 minutes probably, where you started discussing on how to do it. So diagnosis was immediately done. That X-ray was just a kind of a stopgap for you to think more than anything else. You were essentially, flustered by all of this happening and then thinking about how to handle it. Now comes the important decision you took. You decided to pull out the return cannula. And I could see again opinions getting divided. The team, a few members wanted the drainage to be removed, a few others wanted the return to be removed. I wish he had an Avalon. So this problem was not there, all you needed to do was rotate. Right? Finally you decided on the return cannula. Now, before I go further, let me pause here. Why drainage? Why not drainage? Why return? Again, I can drop a pin.
No, most of us thought the return has moved in, so withdraw that back.
Oh, that's easier, right?
I think that
You
was
never
the-
thought through beyond that.
My worry was it would come out. It's a child.
Why should it
it's,
come out?
I mean, like when we are withdrawing.
Oh, that
like-
can happen to the drainage also, right?
Yeah, but at least longer segment.
The
of
drainage is
is
already in
inside.
position now. If we pull it out, it has the holes and all. Some hole will come out, then air will go, and then it will be more complicated. Then the return, maybe 1 centimeter, by that we can pull and see.
What's the challenge with pulling the return cannula out?
It is a short length in, so especially in a
usually
child,
it
I
can
think so.
come out.
Does it come out because it's short? It doesn't.
Okay.
Maneuvers.
Also, the neck
that
is,
nature.
neck is small.
No, it doesn't come out because the patient has a neck.
Has no neck.
Because of the
Why does it come
traction.
out?
Because of the
Sutures
traction,
are
the
not
circuit,
strong enough.
Oh, that can happen with your drainage line
Can be
also.
drainage, yeah.
This is exactly where,
Flexion
I
extension.
find that
Drainage
your
line,
thinking is
even if it
superficial
comes out, sir,
and you need to think deeper into the consequences of what you're doing. The same thing that happened with your decision to prone positioning, I could see that repeating, that pattern, when you decided to pull out the return cannula as well. What's the pressure in the return cannula?
Very high.
No, tell me. P3.
68.
68.
How much is it?
68.
68.
68, yeah.
68 might be wrong, isn't it? Okay, whatever be. It's usually in the hundreds, right? Now what happens to the blood that goes into the right atrium from the return cannula?
Right atrial pressures will increase.
It will
Jet.
go as a jet.
Jet.
So
Exactly.
then the
It'll go as a jet,
jet. So then the
and then
cannula
there will be a
can
recoil,
Rebound. Yeah.
Yeah.
right, from the wall of the right atrium. Do you get it? Now imagine yourself removing all these sutures, holding that in your hand, and the jet pushing the cannula out. It doesn't come out just because it is short. It comes out mainly because there is a pressure that's pushing it outside.
You were were encouraging him to.
Oh yeah, you were all, I was like, I wish we could replicate that in the next simulation. I just want them to do it, and I want the cannula, unless and until you have seen it happen. I've seen it happen. Disaster. And then exactly the same thing will happen as we spoke. Decannulation, blood over the roof. And this is a big problem with pulling the return cannula out. So the decision to return cannula can be questioned on these grounds because you were not prepared for the consequences of it. Yeah. So how do you prepare for the consequences of it?
Flow decrease.
Cut down flows. I never heard you say. We are pulling out the return cannula. Let's cut down flows transiently and then pull it out.
Yeah.
So while your decision could still have been justified, at least you can feel safe that you have done enough to make sure that this doesn't slip off that easily. It can still slip off, okay? So I would always encourage not to go for the return cannula. If you're doing it with the return cannula, be careful. These are some of the precautions you need to take. Otherwise, the person who is pulling it out will be holding the cannula in the hand. Right? Others doing CPR. Okay? Now, why not the drainage? She was hooting for the drainage to come out. Am I right? Were you or you? One of you were.
No, sir.
One of you said drainage should come out.
I thought the drainage cannula was kept more inside. Generally, drainage cannula will be kept near the IVC, and that can be, while positioning the patient, sometimes it can go more inside, so it has to be dragged out. That.
So in this case, the drainage cannula didn't move.
No, sir.
So is it always that you should take the cannula that has moved?
No. Maybe we look at the feasibility, which we didn't do, of course.
So now coming back to you, the people who hooted for the return cannula, right? Why didn't you want to pull the drainage cannula out? Anything you are worried about? Anybody can answer. Though I asked them, anybody can answer. Again, the problem here is superficial thinking. Right? You need to know the consequences of what will happen. Where was the tip of the drainage cannula? It was almost at the hepatic IVC. Am I right?
Yes, sir.
Let's say you're going to pull it out further by say 2 centimeters. How much did you pull it out?
2 centimeters.
2 only. So you're going to pull that out by 2 cm. It'll go into abdominal IVC. What's the problem?
Already he had renal failure and he's just recovered.
Oh, that is, renal is supplied by renal artery, not renal vein. So that problem will not come. What will be the problem here?
The holes we might.
It may not come out. Still may not come out if it is 2 cm. But there is a bigger problem.
IVC pressures might.
You're there. You're getting there. You're thinking in the right direction.
If he's got
improper diet.
He's got a leak.
No, nothing to do with leak. I thought you were.
No, it's a drainage cannula. It will be a lot of negative pressure in the abdominal IVC.
Yeah.
Why?
And
Every time he takes a spontaneous breath, and let's say you're taking off fluid or he's peeing well, the abdominal IVC will collapse. That will be accentuated by your negative pressure in the cannula. This patient with a cannula in the abdominal IVC will only have chattering thereafter. Never in your life will you be able to take off fluid. Never will you be able to wean him down. To do that, you will have to paralyze him. Otherwise, you will never reach your ECMO goals of getting fluid negative. He will spend more time on ECMO. This is one problem with the cannula sitting inside the abdominal IVC. But I never heard you say all these things.
Sir, one doubt, sir. Actually, the question is like the physician want to do proning.
You can always disagree.
We can disagree, but
And I heard you say that very nicely. You said, I'm not interested in it. I was really, I really congratulate you for that decision. Very nicely said. Yep.
Because the plateau pressures were 10 and peak pressures were 24 and X-ray is not completely wiped out.
You can disagree.
So why the first problem of hypoxia has come with the normal X-ray? Is it only just for
Why
the
do you
scenario?
differentiate it as hypoxemia? This patient had a SATs of 94,
100%
PO2 of
FiO2.
55.
He was
So
on-
what? That's how you run VV ECMO. It's only day 13. VV ECMO is run that way.
Okay.
You don't label it as hypoxemia on ECMO. That's normal settings for a VV ECMO.
Others got distracted because of requirement of 100%
I heard you
FiO2.
convince yourself for proning. You convinced yourself in a nice way by saying this is FDO2 of 100%. But that's how you run VV ECMO. These are basics. Why do you want to cut down the FDO2 when on day 13 when lungs have not improved? You just wanted to convince yourself that I am doing proning properly. So you did some tricks and then, okay, finally convinced yourself. Right? Now coming back to the cannula. Right? I don't want to get diverted. The drama is not over. There are a lot of learning things here, okay? So that's where you don't want to pull the drainage cannula down. You can make an argument. In terms of safety, it's safe. But then you can make a counter argument saying that a cannula in the abdominal IVC is going to give me more troubles when his lungs improve. Right? So, again, if you're going to justify you pulling out the cannula, you justify after cutting down the flows.
Yeah.
Right? Would you stop heparin? I never heard you say anything about heparin here.
Don't stop. We are already decreasing the flows, no, sir. How can we stop?
So you don't want to stop. Anybody who wants to stop heparin?
No.
Nobody wants to stop it. So I'm just asking this just to stir the pot. You don't stop the heparin, I agree. Right? Any other problem by pulling the cannula out?
You can ooze from that side, and when he has to re-suture, there can be oozing.
So bleeding from the
Bleeding
cannula side can still happen. Anything else? Something else. Again, you're not thinking deep. What happens when there is constant...
Arrhythmias.
Yeah, probable. Yeah, true. I agree. Anything else?
Vessel injury. Vessel injury.
Can happen. Something you're missing. This will happen the next day, usually.
Clot.
No.
I see bleed.
No. 48 hours after the cannulas go in, the cannulas will have biofilms on it, both on the external surface and the internal surface. By just moving it in and out, what you are doing is you are smearing a biofilm into the circulation in the SVC. You will get to see a SIRS response the next day if this maneuver is done. Very often you will get some low dose NORAD going up, white cells count going up. That's all because your cannula is being dragged. So expect that to happen the next day. Right? I'll stop here. One thing you learn from this scenario, don't give me psychological gyan. No philosophy.
If we are planning proning, anticipate the complication and discuss it.
Well said.
Before reintroducing the cannula, we have to check on the echo and X-ray and have to confirm if needed or not.
Okay, good.
So I think we have to be prepared for the worst when we are doing anything, like whether it's proning or manipulating the cannula. We have to anticipate what complications are going to happen and how to deal with it. Probably we didn't discuss, I mean that should have been the discussion before. We know, but I think we didn't, when you're doing it, so we didn't actually discuss among us. At a team, we should discuss before we do any intervention. It was not an urgent thing to do.
Sure.
Before proning, we have to rule out any correctable causes of hypoxia.
Yeah, fair enough.
You should not get carried away by others' orders.
She's going to kill me.
Primary consultant.
You're questioning the boss. He's asked you to prone the patient and he's gone home. That's okay. It comes at a price. Maybe a volley of abuse later on, but still, you can stand your ground. Yeah, I agree.
I mean to say, maybe we should argue in a healthier manner and decide any other possibility can be there.
So in your case, you are saying there was no indication for prone
Yes.
positioning.
Definitely, sir. The various complications like the arterial removing, once you come out, the arterial, the venous cannulations, the drainage and return cannulas, the pros and cons has to be detailedly discussed and before proning only. As you told, all the complications which we have listed about the flows, everything have been discussed. Yeah.
What did you learn about recirculation in this patient?
So pulling out, like the complications of pulling out the return cannula.
Like
the return cannula pressures are too high, so we have to be careful while pulling out.
Decrease the flows if you want to adjust any return cannula.
We don't need to adjust with the return cannula. We don't need to touch it.
Do everything on the drainage cannula, even if it isn't abdomen.
That can be managed later, sir.
Only when you face it, you'll know. Recurrent chattering, and then you're unable to take off fluid. Your patient will never come off ECMO. I'm not saying what you're saying is wrong. It's safer. What you're trying to say is it's safer to pull out the drainage cannula, which I agree. I wouldn't say not to, but I would put it as it's safer. Yep.
Take care of the infection when you remove
Exactly. So these patients, whenever you move the cannulas, you'll definitely have infection as the complication. One thing again, you'll all need to discuss as part of your anticipated complication is how we're going to deal with accidental decannulation, because you're removing all the sutures and then adjusting. So talk about that as well, so that the team is aware. These are the possible complications. 1, 2, 3, 4 major complications I am anticipating. If this happens, this is what I'm going to do. If accidental decannulation happens, this is what I'm going to do. If this is what bleeding is going to happen, we'll still manage it kind of, post adjustment. That's how you should have that discussion open on this, right?
Reducing the flows also while withdrawing. We reduced
Yeah, he
it,
said
we
that.
saw the recirculation, but for withdrawing we didn't.
Yeah, true.
Did you reduce the flow when you see recirculation?
They did.
Yeah, we did. We reduced that.
I don't know whether it was.
I didn't hear that.
No, we did.
I
We said make it 1 liter.
So my thought process about that exercise was, you just reduce the flows for the sake of reducing it, not knowing it was recirculation.
No, we wanted to.
Fair enough. Okay, good.
Sir, in case of decannulation, what to do? First, we have to clamp the drainage cannula first.
And then one group will start praying, the other group will start cannulating.
We'll compress the site and
start CPR, full ventilation and everything.
Yeah. It's a disastrous scenario.
So in case we can control the bleeding.
So you're lucky you didn't get that.
Another cannula.
And next time we'll bring it. I just want to know how they handle it.
So should we put another cannula once bleeding is controlled?
Compress that area, clamp, so that at least you reduce the damage to the circuit. You may be lucky if air has not entered the circuit, or if too much of blood is not lost. So you'll have to start resuscitating. Again, the group that takes care of the ventilator and the patient will have to focus on realigning themselves for CPR this time, more drugs, how to oxygenate. While the group that is going to deal with the ECMO machine will have to think about how you recannulate.
Meanwhile, we'll circulate the circuit, recirculation.
And so that is one aspect. So the cannulators will have to think about that, while again a subgroup will start thinking about whether this circuit can be reused or whether you need to prime another one.
Okay.
Very often you will end up putting in another femoral line, and it'll be a moment of horror and terror. I don't want to be there.
But it is manageable.
If you are lucky enough, yes, it's manageable.
So Pranay, the best answer would be, it's manageable. You might not cannulate the vein on the other side. You might end up cannulating the artery for a different reason.
Yes, I understand. Post CPR, this scenario.
ECMO.
She was supposed to be our team leader. She did
Yeah, because I'm
Because as a
disagreeing.
team leader, she stood her ground, I thought. I thought,
Because
she was
I'm
clear, no prone positioning. And I don't care what my boss says, no prone positioning.
I think after this I'm going to get from her.
But because we proned, we could able to learn so
It
many
was a
things.
healthy discussion. I liked it because that's how some important decision making happens by the bedside. I mean, your argument was to move forward, which I thought was equally good enough. So such healthy discussions should happen by the when you do your ward rounds or when you take such big decisions.
So the learning point is nothing on ECMO comes without a prize. So if you want to do prone, it's not that it is without prize, it's just anything you can do it. Similarly, you can mobilize each and every patient, you can awake each and every patient. No, it looks good to listen, to talk, but it comes with a price. So you have to be ready for a prize. Okay.
Thank you.
Thank you, sir. Thanks. It was good.
I'll not talk too much. CT platform.